call the left cardiac border, we are actually assessing the left ventricle. That means when you do a PA or an AP view, basically we have two chambers which are cardiac, which are forming your cardiac silhouette. These are just the right atrium and the left ventricle. That means that you cannot fully assess the left atrium using a PA or AP view, nor you can assess the right ventricle when you are examining a PA or AP view or a frontal chest X-ray. So it's atrium or left ventricle which you are able to assess when you do this examination, frontal examination. So just to give a picture, so this is the right atrium, because if you notice, this is the orientation actually of your heart. Basically, it's quite it's placed obliquely, wherein at the right side you just have the right atrium. At the left side, you have the left ventricle with the cardiac apex at this portion. So this is the cardiac apex. So remember also the cardiac apex, because some radiologists would also describe certain pathologies of the heart using the term cardiac apex, which is the tip, actually, the angled portion at the inferior portion of the left side of the heart. And centrally, actually, here at this portion is your right ventricle. Now, radiologists usually, when they assess the heart, they assess the different moguls of the heart. Moguls, that means these are bulges in the cardiac silhouette or the mediastinum. So basically at the right, we just have one mogul, which is the right atrium. This one, you just have one bulge here, one big bulge, which makes up the right atrium. On the left side of the heart, basically you have 5 moguls. Some of the moguls are actually just seen in cases which are pathologic. So the first mogul actually makes up your aortic arc, or what we refer commonly as your aortic knob. So this makes up the arc or the knob of the aorta. The second mogul would be your main pulmonary artery, left side, left main pulmonary artery. The third mogul would be your prominent left atrial appendage. So as you know, not only that you have 4 chambers of the heart, right atrium, left atrium, right ventricle, left ventricle, you also have appendages. And for the left atrium, when the appendage is enlarged, usually common in this is quite common in cases of mitral rheumatic heart disease, wherein you have some mitral issues, mitral problems. So basically, this left atrial becomes prominent. But once you see this prominent left atrial appendage, that means there's a pathology. Normally, you do not see this mogul or the prominent left atrial appendage. So at this point, what's just normal is aortic arc, main pulmonary artery. When you see the third mogul, that means there's something wrong. The fourth mogul is also normal. It would be the left ventricular margin. Okay. And lastly, you have the cardiophrenic angle. The cardiophrenic angle, fifth mogul, actually usually represents the pericardial fat pad, but at times it also represents other cardiophrenic pathologies. Actually, for the fifth mogul, when you see it and it's lucent, and most likely when it's pericardial fat pad, bali taba lang na siya actually yung nag-surround no sa inyong heart. This is actually a normal variant, meaning normal lang eh. But it doesn't mean that all the time when you see the fifth mogul, it's just pericardial fat pad. There are pathologies, just like a pericardial cyst, or cardiophrenic cyst, which can also be located at this point. So to sum up, for the left moguls of the heart, you just have the aortic arc, main pulmonary artery, and left ventricular margin, which you normally see. When you see the third, there must be something wrong. When you see the fifth, it can be normal. It can be just a pericardial fat pad, but it can also represent a mass lesion or a pathology. So this is just to give you a better picture, no? So sa right atrium, the mogul, the only mogul at the right. Then you have here the aortic arc, first mogul, main pulmonary artery, the second mogul, the dilated left atrial appendage, the third mogul, which is pathologic, the left ventricle, and the pericardial fat pad, which can be normal. So actually, between the aortic arc and the main pulmonary artery, at this point, we also have another term that we use that would be your aortopulmonary window. So between the first mogul and your second mogul, this portion here is also called the aortopulmonary window. I'm introducing it to you because at times radiologists, there are lesions which are located at the pulmonary window. So when they say aortopulmonary window, that means that's the convexity between the aortic arc and the main pulmonary artery. So now let's talk about heart enlargement. Through X-ray, is it possible to determine which chamber of the heart is enlarged? The answer is yes. But for most, when we do chest X-ray, we do just using the front, the PA view. We are already able to assess if there's a certain degree of cardiomegaly or heart enlargement or not. In the pediatric group, usually less than 6 years old, we do not do PA view. Usually in the pediatric group, the standard examinations or requests that you do would be APL. And what we do actually to assess the heart would be to get the cardiothoracic ratio. That would be the ratio between the heart and the widest portion of the thorax. So we get the length from the right cardiac border to the left cardiac border. We get the length of this. Then also we get the length from the rightmost portion of and the widest portion of the right hemithorax up to the left hemithorax. Then we divide A and B. So let's say you have the distance of the heart is A. That is let's say the distance is 12 here. Then here the measurement would the width would be 24. That means that 12 divided by 24, you have 50 or 0.5 cardiothoracic ratio. So the cardiothoracic ratio is actually interpreted using a decimal, no? So it's either 0.5, 0.54, 0.6, 0.67. Normally, for the pediatric group, the cardiothoracic ratio should be less than 0.6 in AP view. For the adult, it should be 0.5. And if the patient, the procedure for the patient is AP view, wherein there is magnification of the heart, which I think Dr. Dumagit already have mentioned to you the reason for magnification. So the cutoff is actually much higher. That would be 0.57. But some radiologists would use 0.6. But technically, it's actually just 0.57. So again, for the cardiothoracic ratio, when you do PA for the adult, it should be 0.5 or less. For 0.51 cardiothoracic ratio, we call it top normal. It depends upon the radiologist, but for me, when the cardiothoracic ratio is already 0.52, I already call it mild cardiomegaly. Some radiologists, a cardiothoracic 0.52 would still be top normal. Then they would start calling it mild cardiomegaly at 0.53. Nevertheless, for equivocal cardiomegaly, that would be between 0.52 to 0.5. It would be better that you correlate it with other diagnostic parameters such as ECG or 2D echo if it warrants. Now, this is a case actually wherein you have a very large heart. You usually see this if the patient is actually Caucasian. You see this actually in cases of Ibstein anomaly, EIBSTEIN, Ibstein anomaly. This is a back-shaped heart. But in the Philippines, usually when you see this very large heart, usually you can commonly see this in cases of rheumatic heart disease. So this one actually, you also have an enlarged heart, but basically, if you notice, the shape is quite different. This one, the shape is globular. It's enlarged but globular. This one, if you notice, the shape is resembling a water bottle. And this is actually, in these cases, we cannot rule out pericardial effusion, though it's really quite different to determine whether it's pericardial effusion or just plain cardiomegaly. There are actually signs that the radiologist are able to utilize in order to clinch whether it's actually pericardial effusion or cardiomegaly. But one of those actually would be the shape. So usually pericardial effusion would be manifested in a chest x-ray when the volume of the fluid within the pericardium or in the pericardial space would be more than 200 ml. So this is actually what we call the water bottle sign. In cases of pericardial effusion, it's that the shape is not globular. If you notice, there's some it's quite different from the first cardiomegaly images which I've shown you. Now the question is, would we be able to determine chamber enlargement through X-ray? Can we pinpoint which chamber is enlarged, whether it would be right atrium, left, right ventricle or left? Yes, actually we can do that, but of course you have to do not only a frontal view but also a lateral view. So just like in any case, when you do localization, we usually use both the frontal and lateral. However, actually there are other actually views that we can still utilize in order to clinch whether it's a right atrial enlargement, a left atrial enlargement. We have what we call an antero-posterior oblique, a posterior-anterior oblique, right and left. But usually, clinicians don't request those, not unless the radiologist would advise that those certain ancillary procedures, the anterior posterior oblique or the posterior anterior oblique or left, should be done. But nevertheless, it's safe that when you are suspecting a cardiomegaly at a certain with a particular chamber, you can do an ancillary examination, lateral view, in order to further evaluate the condition of the heart. At this point, am I still clear? Okay ang akon nga signal? Okay ang aton connection?
Yes, Doc.
Okay, sige. We'll proceed. So actually, when we talk about heart enlargement, there are